Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Cardiovascular disease remains the leading cause of death worldwide, yet advances in lipid management are rapidly reshaping how clinicians prevent heart attacks, strokes, and other atherosclerotic cardiovascular events. With evolving guidelines, more aggressive LDL-C targets for high-risk patients, and an expanding arsenal of therapies beyond statins, including Zetia, PCSK9 inhibitors, bempedoic acid, and emerging agents such as Enlicitide, clinicians are navigating an increasingly personalized approach to care. In today's episode, we'll examine the evidence surrounding Enlicitide and explore where this emerging therapy may ultimately fit within the evolving landscape of lipid management. Joining us today is Jodi Martinez, Pharmacist Clinical Specialist in Cardiology at the University of Colorado Hospital, part of UCHealth.
I'm Kerry Schwarz, Senior Clinical Manager for Evidence-Based Medicine and Outcomes with the Vizient Center for Pharmacy Practice Excellence.
Jodi, welcome to the program.
Thank you, Kerry. It's a pleasure to be here with you today.
Jodi, what are the limitations of the current state of lipid management?
We have a handful of agents. We have our statins. That's our foundational therapy for lipid-lowering agents. And then we have the agents such as ezetimibe, bempedoic acid, and most recently, there's been an explosion in our PCSK9 monoclonal antibodies and just other agents. So we have evolocumab and alirocumab. Those are our monoclonal antibodies that are injectable for PCSK9. We have inclisiran, that is a small interfering RNA that inhibits the production of PCSK9. And then most recently, we have lorodalcibep. And then we also have Enlicitide. Enlicitide is really exciting. It was just FDA approved of July 16th of 2026. It's our first oral agent to hit the market. So now we have first oral agent as in non-statin therapy. So now we have this arsenal of therapies. And what we know is that our LDL targets keep moving. They keep getting stricter and stricter. From the 2022 ACC Expert Consensus Decision Pathway in non-statin therapies, we see that in our ASCVD in our highest risk patients, we see that again echoed in the 2026 Multi-Society Dyslipidemia Guidelines. We're seeing that these targets of LDL are lower and lower, and our highest risk patients are less than 55 milligrams per deciliter in their LDL cholesterol goal. And we know that less than 50% of our patient population, or about 50% of our patient population, they're not meeting their LDL targets. So it's really exciting that we have this arsenal of agents. Hopefully it'll overcome some of our barriers, being that historically our PCSK9 injectable agents are all specialty medications. So they're high cost, they require prior authorizations. Insurances sometimes have step therapy. So they'll say, okay, before we approve your evolocumab or alirocumab or other PCSK9 agent, they're going to say, we require ezetimibe. And sometimes that can be discordant with our current guidelines, especially the 2026 guidelines.
Sounds like there is a robust menu of choices here, but it also sounds like we have room to improve. So let's talk about the evidence behind this new agent, Enlicitide.
It is indicated as an adjunct to diet and exercise to reduce LDL cholesterol in adults with hypercholesterolemia, including adults with heterozygous familial hypercholesterolemia. And the studies here that really support that FDA indication and labeling comes from the Coral Reef trials. So this was a multi-center, double-blind, randomized placebo-controlled trial with nearly 3,000 patients. And it included patients with hypercholesterolemia with a history of ASCVD, so atherosclerotic cardiovascular disease, but also patients who didn't have a history that were just intermediate to high risk of having an event. Patients had to be receiving high intensity or moderate intensity statin or just stable on their background lipid-lowering therapy before entering this trial. But they were randomized in a 2-to-1 fashion to either Enlicitide, 20 milligrams daily, or placebo. They excluded patients who were getting an injectable PCSK9 or had recent use of a PCSK9 inhibitor, patients who were uncontrolled diabetics, active liver disease, or maybe high triglycerides that were greater than 400. Their primary outcome was a mean percent change in LDL from baseline to week 24. What I was really excited about was their secondary outcomes. They looked at a percent change in LDL from baseline to week 52, but then they also emphasized a mean percent change in ApoB, in non-HDL cholesterol, but then also a percent change in lipoprotein at little a to week 24. This was pretty cool that they emphasized those as their secondary outcomes. What they saw in the primary outcome is that there was really a reduction in mean LDL from baseline to week 24 that was roughly 57.1%. So this is fantastic, very potent lowering agent, especially for an oral PCSK9. And then for their secondary outcomes, their mean change in LDL cholesterol from baseline to week 52 was 47.6%. And then their mean change in non-HDL cholesterol was 53.4%. And the change in ApoB from baseline was roughly half, so 50.3%. Their Lp(a) decreased by about 28.3%. So this is all really fantastic because it aligns directly with what we've seen in other PCSK9 trials. So we're seeing roughly 50 to 60% lowering in LDL cholesterol, which is fantastic. It means we're being consistent. I love that they emphasize that these secondary outcomes because that really aligns with our 2026 dyslipidemia guidelines where they highlight and call out ApoB targets and goals now. A limitation of this study is that it doesn't show cardiovascular outcomes. That trial is still ongoing and it's anticipated to be completed December of 2029. So we'll just have to wait for those. But overall, a very exciting, positive clinical trial.
This is exciting, and we'll all be watching for those cardiovascular outcomes, right? Is the true clinical outcome here. How could this new agent address some of the gaps in care that we talked about earlier?
Being in the ambulatory setting, I am most excited about the access to this medication. It's an oral medication and it's not considered a specialty medication. It's going to be available at retail pharmacies, which is different than what we've seen with PCSK9 injectables in the past. They're specialty medications, they're high cost. Primary care physicians would shy away from injectable therapies and oftentimes refer to specialty clinics or their cardiologists to get them started on PCSK9s. This has the potential to remove that barrier and just be another oral agent after someone's on a statin therapy and still not at goal. Price can play a huge role in this as well, because when you have these injectable therapies, they're high cost. And a lot of patients that I assist in my setting, they're on Medicare. Getting them on these therapies can be pretty tricky because after you get them approved through their insurance, then they're high cost. You're kind of stuck having to navigate the financial barrier. Enlicitide, being that it's 50% of the price of these injectables, it has the potential to have more access to patients, not only from a prescribing standpoint, but also from a cost standpoint. This is going to be more accessible to our primary care, to a lot of patients who maybe have hesitation around injectable therapies. This is the first time that we have such a powerful lipid-lowering agent that is available in oral form.
It's really important to focus on increasing access to these medications, and that's fantastic. But not everything's perfect, and there probably are some barriers associated with Enlicitide. What do you anticipate those are going to be?
What I see commonly is that insurance payers, they lag behind guidelines and they lag behind when medications are newly FDA approved. It takes them anywhere from 6 months to a year to review them on their formulary and get them added. We have an FDA new approved drug and has the potential to increase access. And so providers get really excited and they start prescribing it. And then we run into insurance issues where they say, oh, we haven't reviewed this to formulary. Why can't they be on an alternate therapy? So then that really falls back to the clinics and the providers to do the paperwork, to do the appeal, to follow through with the appeal, submit that, follow up on that. And so that can be a lot of time and a lot of burden to clinics who are already overwhelmed with the day-to-day. That is the biggest barrier that I see, is it just takes a lot of time to argue with these insurance companies and help get these medications into the hands of the patients. The other potential barrier I can see is that how will this be tiered without published cardiovascular outcomes? LDL is a surrogate marker. It's always nice to see those hard outcomes represented and these MACE outcomes reduced in a cardiovascular outcome trial. That could influence where this is in payers and their tiers, or even in the guidelines, because they tend to favor drugs that have potent LDL lowering as paired with those cardiovascular outcomes, such as our monoclonal antibodies like alirocumab and evolocumab. It's always nice to have that full picture and saying, okay, yes, it has potent LDL lowering and the cardiovascular outcomes. We're anticipating to see positive results in the cardiovascular outcome trial, but we do need to wait until those are published to officially say that. This could have a little bit of slow uptake until insurances have this more widely on their formularies and available to patients, going back to those barriers that the clinicians are going to have to battle with insurances to get this approved for their patients in the meantime.
There's always that saying, don't be the first, but don't be the last. That sort of influences uptake of any new therapeutics. As we accumulate more data, we'll start to figure out, well, what is this agent's place in therapy? What are we going to do with that? Looking into your evidence-based crystal ball, what do you anticipate this new agent's place in therapy?
Statins are obviously going to remain the cornerstone. Majority of the patients in these CORAL trials, they were on a statin therapy, moderate or high intensity. So over 95% of them were. So that is going to remain our cornerstone. Patients need to continue their statin, be on a statin. But after that, if patients aren't at goal, what I do in my clinic is I really look at how far are these patients from their LDL goal? Are they going to need more than 20% lowering? We know that with our other oral agents like ezetimibe and bempedoic acid, they lower your LDL by about 20%. So, hey, if they're pretty close to goal and you just need a little bit lowering, then those agents can be a good option. They're still in your toolbox. Enlicitide, though, I see as being an option after statin therapy when patients still aren't at goal. They need more than 20% LDL reduction to get to their goal. And they've had an event, let's say they're an ASCVD patient and they really need that intense therapy. I really see it as an add-on to statin therapy, just like we saw in the Coral Reef trial. I see it as an alternative to the monoclonal antibodies, especially once we have those cardiovascular outcomes. It'll be in an equal line with, you can choose alirocumab, evolocumab, or enlicitide as an agent that would be high on your list and to reach into the toolbox when you need that LDL lowering.
We'll all be watching this closely, of course, waiting for those true clinical outcomes, those cardiovascular outcomes in the next few years. And it'll be really interesting to see how this plays out, particularly around the access issues. So, Jodi, thank you so much for joining us today. This has been terrific.
Thank you, Kerry. It was a pleasure.
Subscribe today. Like us. Send us your comments. We'd love to hear from you. Verified Rx is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.